just again, welcome everyone, and just appreciate you, weathering the storm, coming all out of your bedrooms and kitchens and wherever you're coming from in your house to be with us this morning. I see some familiar names, and so Tom Bogan, and Thea, Mary Smith, all of you, we welcome all of you. So my name is Mary Diggs Hobson, and I'm going to just kind of give you a little bit of information about who we are and what we are about as far as African Americans Reach and Teach Health Ministry, or you may know us by ARTH. We are a non-religious 501c3 faith-based capacity building nonprofit organization. We were established in 2002 to respond to the HIV/AIDS crisis. And we've expanded over the years to really look at other chronic health conditions that disproportionately impact our people of African diaspora who are living in Washington State. We also cover parts of the federal region. Primarily, ARTH works to increase the capacity of our faith and health institutions to provide equitable and culturally responsive wellness and community care systems for our people. And that includes health awareness, education and training, like the session that you're attending today, promoting affirming health practices. And we really focus on strengthening the infrastructure of our institutions so that they may be able to provide culturally responsive services. We do a lot of collaborating with our providers, clinics, hospitals, and other organizations across the state. This morning, we're really happy to be partnering with New Beginnings, a Christian Fellowship Church, their Ministries of Health and Well-Being. And we have the wonderful, gorgeous, beautiful, awesome Joycelyn Thomas with us, who is the wears many hats. One of them today is as the director of the health ministry at New Beginnings. And then we're really happy to be able to bring this to you because we receive funding from King County and their Veterans and Seniors Human Service Levy that allows us to bring this to you today, and many other sessions that we have planned over the coming months. I just want to bring your attention to the fact that this session will be recorded. And also we will be sending out after today's session a kind of a post-evaluation. We need to hear from you about how we're doing. If this session was helpful to you, if it answered questions that you came in with, and so on, so that we can know in future how we might need to change or improve our sessions. And so at this point, I want to introduce our presenter, Ms. Pamela Saari, who also wears several different hats. And she is a board certified family nurse practitioner with training in social work and public health. She's very passionate about facing and reducing the effects of HIV on African-American community and engaging patients and clients where they are in their learning as we are today as we work towards improving our knowledge around our health journey. So at this point, I'm going to turn it over to Pam, who will take you from here.
Mary, before Pam starts, can I just say one thing?
Sure.
All right. I just want to let you all know that we worked very hard to bring to the table for you something that would be informational. And really, this is going to be a time for people to engage with the speaker today, our wonderful speaker. And we can get super technical and we can also be very lay. So I'm going to let Pam go ahead and get started, but I just want you to know this is an open time for us, and we hope to spend most of our time answering your questions and fielding your concerns.
Hey, thank you, Joycelyn. As Mary said, my name is Pam. I'm a nurse practitioner, and today we're going to talk about COVID, the virus, the disease that it causes, and the vaccines that are available for it. And like Joycelyn said, what we really want to get at are the questions from the audience. Now, the slide presentation, it's about 20 slides, and they can explain several concepts. But I feel that there are probably several folks on the call today who have a lot of different points of view with virology, with social services, with all of that. And I invite you to jump in where you feel like you have some information to contribute. So first, what I want to do is to make sure that everyone gets their questions answered. And so I would actually like to take this time to ask you to go to the chat box and to type in the questions that you have. And if Twanda and Joycelyn can help, we can keep track of the questions and answer them as they come. So does everybody want to take just a couple minutes and put in questions that you might have that you brought today?
Twanda.
I have a question.
Yes, who's that?
Pam.
It looks like people are a little bashful this morning, Pam. I think once we get going.
Okay.
Okay, here we go. We're starting to get one. We got two questions in the chat box. How safe is the vaccine? And what if you never get the second vaccine after being given the first?
Okay, let's go.
Another question, will the vaccine give you COVID? And then which vaccine is better, Pfizer, Moderna, or the new one coming out?
Okay.
Those are great questions.
Those are great questions.
Oh, one more. And are vaccine side effects more pronounced in different races?
That's a good question.
Yay.
Okay. All right. So why don't we share? I'm going to share my screen so that we can, there's another two.
How are you all addressing the equity issues that are arising considering access? Hold on. Can you speak to the long-term strategy for vaccinating the community, cultivating trust while doing so, and making sure the data narrative is / are valid and transparent? That's a great question, and we can answer that one. Another one has a family that's adamant about not taking the vaccination. Can you please explain in layman's terms the benefits, possible side effects, and consequences if we don't take the vaccination? Those are great questions. Okay,
those are wonderful questions. I love those. So what I want to do is share my screen here. First, I'm going to begin the show. Okay, hold on.
And while you're doing that, Pam, I've been told that second vaccines present, oh, okay, I got to come back to that one. Go ahead.
There we go. Okay, let's move on down here. We've got, so I have no conflicts of interest. I don't work for any of the vaccine companies. The objectives for today are the questions. We want to answer those questions and understand the basic structure of a virus, become familiar with the variety of vaccines, and understand vaccine targets and how vaccine work to slow the spread. Through that information, what I hope to do is answer some of the questions along the way so that we can see why it's important for the entire world, basically, to get the vaccine. But in our country, why it's important for African Americans, since we're in the context of talking about African Americans today. So definitions. So SARS, I don't know how many of you remember that from a few years ago, from I think that was 2012. But SARS stands for Sudden Acute Respiratory Syndrome, okay? Now, the virus that causes COVID is a SARS virus. It is called SARS-CoV-2 because it's the second one from 2019. That's where we get the term COVID-19. Now, COVID-19 is the disease that is caused by SARS-CoV-2, not 1019, 2019. And CoV stands for coronavirus, okay? So we're going to talk about just the nuts and bolts of what is a virus. A virus is a very, very, very simple thing. It is just a small, tiny, tiny entity with a protein coat and a bit of, well, nucleic acid. Nucleic acid is like DNA or RNA. So COVID has just a little tiny bit of RNA inside. That RNA is what makes COVID COVID. It's what tells the cells that COVID goes into how to make more COVID. So we'll get to that because I have a little movie I want to show you just on the process of how a virus replicates. And we're gonna do that here right now. This is only a couple minutes, but it's kind of interesting. The RNA genetic material inside. You can see the protein coat. These are the spikes that we are all talking about, that we make the vaccine from. Now, this is a great representation of water droplets going through the air. And then getting into, say, a lung cell. It sticks. It opens up the side of the cell. And when the virus infects, it goes into the nucleus of the cell. And it hijacks the cellular machinery and tells the cell to make more virus instead of whatever the cell was doing before. Packages new virus, and then it'll export it out of the cell to go to other cells in the body. And this happens trillions of times, over and over again, while the virus is active and replicating. Okay. Okay. So coronaviruses are a large family of viruses that usually cause mild upper respiratory tract infections like the common cold. So common colds are actually coronaviruses. But some of them cause major outbreaks. And in the last couple of decades, there's been two coronaviruses that have been major causes of death and illness in the human population, and that is SARS, like I said before, and then that's MERS. That is the Middle Eastern, what does the E stand for?
That's it.
Middle Eastern Respiratory Syndrome. Okay, thanks. So how did we get the coronavirus? Coronaviruses are known to start in animals and then jump to humans. In this case, this virus started in bats, it jumped to a mammal called a pangolin, and then it jumped to humans. And how it got to humans from the pangolin is that in China, the pangolin is a delicacy form of meat. So it was through slaughtering the pangolins that jumped to humans. So, COVID-19 disease. The symptoms that appear 2 to 14 days after exposure of the virus are fever and chills, cough, shortness of breath, difficulty breathing, that feeling like you just cannot take in enough air, profound fatigue, body muscle aches and pains, headache, loss of taste or smell, sore throat, congestion or runny nose, nausea, vomiting, or diarrhea. Now, some people only get the diarrhea part. Some people only get fatigue, headache, and body aches. Some people get just the shortness of breath and all that, and those folks end up in the hospital on ventilators. So all of these symptoms should be a consideration if you feel or know you may have been exposed to coronavirus or that your family was exposed to coronavirus. Now, what's really interesting about this virus is that there are some people who do not show symptoms at all, yet they are very infectious. And that's the problem with this virus, that you can be around someone who appears to be completely well, yet they are breathing out virus with every breath or every song note, everything that they're doing, every time they yell. So there are risk factors for development of the severe disease that ends in hospitalization, intubation, and death. And intubation is when they put you on the breathing machine. So if a person has cancer and taking maybe an immune modulator for cancer, and when you have cancer, your immune system is weakened anyway. If a person has chronic kidney disease, chronic obstructive pulmonary disease, a heart condition such as heart failure or coronary artery disease, an immune system that's in a comprised state, that's people who have had an organ transplant and so they're taking immune suppressors, people whose body mass index is greater than 30, and people whose body mass index is also above 40, that's severe obesity. Pregnant people, people with sickle cell disease, people who smoke, and people with type 2 diabetes. Now let's look at this list. In the African American community, we have an overabundance of people with all of these issues. So how many people do you know who are diabetic, who are overweight, who have heart conditions? They have hypertension, and so they've developed some heart failure that they may or may not even know about. They have a chronic obstructive pulmonary disease from a lifetime of smoking, or they're active smokers. They have chronic kidney disease. Folks who have hypertension often develop chronic kidney disease towards midlife and into being older. And advanced age is also a risk factor. So African Americans account for a higher proportion of COVID hospitalizations and death than do Caucasian people. So this slide is telling us the rates, the ratios compared to white non-Hispanic people. Okay, so cases, African Americans have 1.4 times as many cases as white people. Hospitalizations, we are 3.7 times more likely to be in the hospital, and deaths 2.8 times more likely, almost 3 times more likely to have deaths from this disease. So when your family asks you, should they get it or why should they get it? This is why. Because we are bearing, again, the burden of this disease in the population. So, this slide just shows for age. As age increases, as you see age increasing going down the right, the left column on your page. By the time you get up to people who are, 75, 85, they are 8 times more likely to be hospitalized, 8 times more likely, 13 times more likely to hospitalize if you're over 85. And deaths, look at those deaths. A lot of the deaths are really concentrated around the advanced age group. However, do not be deceived. There have been many people who are young people who developed symptoms like neurological symptoms associated with COVID that actually ended up dying. Some respiratory, a lot of young people smoke or vape. All those things can compromise you. So this is my slide on equitability. One of the issues that goes on is the distribution and the availability of the drugs that help to stop COVID disease. Now, early in the disease, you can help to keep it from advancing farther if you can give people the remdesivir drug, the antiviral drug, and if you can give them what's called convalescent plasma. And convalescent plasma is blood plasma that's taken from people who have had COVID and recovered. So they take their blood, they take out the plasma part of the blood, and they concentrate the antibodies that are in there, and they re-infuse them into a person who's newly sick. That's what they did with Donald Trump. And that's why at 75, in his health condition, he survived and was only in the hospital a few days. And the other part of that is that we really don't know how much basically hospital care he got inside the White House once he got back. We weren't privy to that. So we really don't know how long he was really sick, but his illness was arrested because he had those things. Now, it's the distribution of that is being the big problem here. At first, the cost for the remdesivir was very high, and hospitals just didn't want to buy it because they didn't have the money for it. With the influx of so many people, they were just slammed, and financially they couldn't hack it. Now, when you also look at hospitals in poorer areas, they didn't have enough PPE. They didn't have enough gowns, masks, all that sort of stuff. And you remember that from when New York first had its big. I'm sorry. when New York had its thing there. So anyway, the poor hospitals in the area suffered way more than the hospitals that were in richer parts of town and in richer parts of the state. So hospitals have turned down allocations because they couldn't afford it. So what can I do to protect myself and my health? Even after the vaccines, the thing that we can do is continue to wear masks. The new recommendation is that you wear 2 masks. You wear one, hopefully a KN95 or an N95, and then you wear over it maybe a surgical mask, okay? This is a KN95. Hopefully you didn't get that there. Are we seeing that?
Get closer. There you go.
Okay.
Oh, there. Okay.
What's going on there? There we go.
Yeah.
Okay. You see it's in a package. And on the side, I don't know if you can see that, it's stamped. Okay. You want to wear it so that it goes across your nose and has a good tight fit around your face. Okay. And then you can just wear like a blue surgical mask over it. It just gives more barrier for the virus to get through if it's coming at you. You want to practice social distancing, at least 6 feet. You need to stay at least 6 feet from anyone you do not live with. That includes at work. So when you're talking to your coworkers, you need to stay 6 feet from them, at least, the very least. 10 is good, better. We need to get the vaccines that are now being offered, and we need to encourage our family and friends to get them. So let's talk about the vaccines, how vaccines work. Usually the way that vaccines were made, that we would get a weakened or killed antigen like a virus. We would put it into some cells, grow antibodies from it, and basically look to see if those antibodies that grow can then go back and attack a live section of the virus. Once we figure that out, you basically make a vaccine from a killed or section of a virus, and you inject that into a person. And then the people make the antibodies because you know that that's going to work, right? That's the way it worked with smallpox and all the others, okay? But now we're doing a new type of product. It's called an mRNA vaccine. And basically what it is when you go back to that movie where you saw the virus putting its DNA or its RNA, whatever, into the cell, it made the cell make a messenger RNA for its proteins. And then the cell used that and made the virus's proteins over and over and over again. But what this vaccine does is it takes a messenger RNA that is coding for one of these spike proteins on the virus there. It puts it into a lipid coating, and that's injected into the body. Once that's injected, these messenger RNA signals are picked up by immune cells, and the immune cells look at that and they make antibodies to that target, and that's the target that they're making the antibodies to. So if a person comes in contact with this and these spike cells are there, these antibodies go around it and box it in. They mark it so that what are called natural killer cells can come and take it out of body circulation.
Pam, I'd like
Yeah.
I just want to let those who are in the audience know, I want to reiterate what Pam said, and that is you're not getting a live or dead vaccine, live or dead coronavirus injected into your body. I want that to be really clear because those are a lot of questions that I get, is that, am I getting a coronavirus injected into me? You are not. You can say that with confidence, okay?
Right. And that is why you cannot get the disease from this, because this is nothing but a string of nucleic acid, RNA, that is only coding for a little tiny piece of the virus. It isn't even a little tiny piece of the virus itself. So you cannot get disease from this. Okay. So getting a vaccine is an integral part of reducing and eliminating the spread of the infection. And that's because the more people that are vaccinated, it'll do two things. They will, if they do get the virus with the vaccine, they will have a very, very much milder course of disease. The vaccine cuts down on hospitalizations and death. People won't die anymore. That from the virus. On the other hand, too, I was going to say something else. When enough people get the vaccine, the virus cannot jump from person to person as fast. And so it can't mutate as fast, okay? So all of these variants that we're talking about, if the virus stays put and we kill it in one person, it doesn't go to another person. Viruses aren't alive. They can only change when they're in a person. They can only change when they're in a person. So if we have people with vaccine, we have people social distancing, we limit the amount of contact the entire population gets with the virus, and the virus stops mutating, the virus stops hopping from person to person. We get down the level of the virus in the population altogether. So when we reduce cases, it takes pressure off the healthcare system. There aren't as many people presenting to ERs and needing to be in ICUs. We save lives. So why don't we go on to the questions that we had? So what was the first question?
Which vaccine is better to take? Which is the best one?
Okay, let me see. I have a thing. Here's my vaccine activity. All right, when we first got the virus, we started making vaccine to what we call the wild type or Wuhan strain. And what we find is that Pfizer and Moderna both have about 95% activity against the virus, okay? They have very, very, very high effectiveness against that virus. AstraZeneca doesn't have quite as high, but the AstraZeneca's claim to fame is that they can verify that if you take the AstraZeneca, it will prevent you from actually contracting the virus. Pfizer and Moderna have not done the tests yet to see if that's true of their vaccine. But if you do get the disease and you have Pfizer or Moderna, they're equivalent. And it will help you not to get as sick, not get hospitalized, and not to die, okay? So against the new strains, the new variants. Now we get these variants, remember, because there's been a lot of ambivalence about wearing masks all the time and social distancing. So every single time there's a situation in which lots of people are crowding together, sort of en masse, we have a chance of passing the virus. And every time you pass the virus, it changes just a little bit. So in England, they got a new strain. And so they've tested the virus against the vaccine against the new strain. And the Pfizer vaccine is completely, it is effective against the new strain. The Moderna has a little bit less immune response, but still above the level that's perfectly adequate to attack this particular strain. And AstraZeneca, of course, it was made in the UK. So AstraZeneca also attacks that new strain. Now, when you get down to the other variants, the South African variant and the Brazilian variant. So the South African variant, AstraZeneca has no effectiveness at all. Okay, so this one, the South African strain, there are cases in the United States, but it's not very big yet. The one that's coming to sort of take over from the wild type is this UK strain. So what we hope is that we can get enough vaccine into the entire country to prevent widespread transmission of this South African strain. So, but Pfizer and Moderna have some protection against that strain, but it's much less than it has against these other two. In all likelihood, from what I read, the Pfizer and Moderna will have to have a booster to address the South African strain or the Brazilian strain. Now, the Brazilian strain research is proceeding. We don't know how much effect this has, but this one is also there aren't a lot of cases in the United States. That doesn't mean there won't be. It just means that they're not right now. But these companies are working night and day to try to meet and protect against the different variants that pop up. But we can help them. We can help them not have to work so hard if we get the vaccine now, continue double masking, social distancing, washing the hands, and just keeping the virus from jumping from person to person. We need to take away its ability to basically get better and better at killing us by basically not allowing it to spread.
And I'd just like to add to what Pam said to just alleviate any concerns about variants. It's not abnormal to have variant strains of virus. That happens with all viruses. We anticipate variant strains. So the public gets scared. Oh my God, there's a new virus out, there's a new strain out there. What are we gonna do? So what usually happens is they usually come and then they go. And then sometimes they come and they persist, but we can really help it to come and go like they normally do by getting vaccine, as Pam described. So I just want to put that out there that the variant, this is not unusual. This is not a new thing. COVID's not, any different than any new virus. It's just that we don't talk about it in the public when we talk about, there's all kinds of variant strains of influenza virus. There's tons of them. And they just guess every year on which one is the best one to vaccinate against that year. So I just want you to understand that. So when people are like, I'm not going to get the vaccine because there's all these new strains and I'm just going to wait. Well, that's the worst thing you can do.
Sure.
I hear that a lot in the community. So, okay.
That's a great point. Great point. So that's our immune system. So these are just the slides for questions. So let's go to some more questions.
Okay. The next question was, let's see here. How safe is the vaccine? So they're talking about safety. And what if you never get the second vaccine after getting the first?
Okay, let's.
I can tell you that one. That's great.
So the safety. Let's talk about why the vaccines are safe. I know that sometimes people say that the vaccines aren't safe because they produced them too fast. Well, let's talk about what happened in that production. The first thing that generally happens when they come up with a new vaccine is that they get volunteers and they test it to see if it makes a well person ill in some way. Is there a side effect that we really don't want in this medicine, this vaccine, this pill, whatever it is. that once that first phase guarantees or they're satisfied that it's not going to hurt people, which is what we've done with this, it moves on to see, does it do what we think it's going to do? Is it going to make antibodies to this virus? And once we find that out, then we go to the stage where we try to decide, well, how big a dose do you have to give people? Okay. And all of these jumps, as they go on and they're getting bigger and bigger and bigger samples of people, they're looking for bad outcomes, allergies they didn't anticipate, all kinds of things is what they're looking for. Now, the reason this vaccine was able to be made so fast, quite honestly, is because all of the different steps in producing the vaccine, they were done in parallel instead of being done one sequentially after the other. The other thing is that I believe this is probably the first time that there was a complete countrywide, worldwide effort to come up with an answer to a scientific question. Usually pharmaceutical companies are competing against each other. And so it takes them longer to do these things. But when everybody is throwing in all bits of information and people who do this type of science better are doing this part and all that, it's easy to come up with answers to questions. And that's how this happened. So there weren't any steps that were missed. It wasn't like, oh, we isolated it and we ran to the public. It was tested very thoroughly in the way that it needed to be tested. Then after that, not the companies, but a whole separate group of scientists looked at all of the studies and all of the data to make sure that what AstraZeneca, Pfizer, Moderna, to make sure that what they said was actually true, that there was no mishaps in the data, no misinterpretations, no lying, none of that. So all of that was done by a whole third party. Now, sometimes people get confused with, the whole political thing that's going on. I want you to understand that just like in your job, you have pride in what you do in your job. The scientists who are doing this have to put their names on it. They don't want to have bad work out there with their name on it. And they care about people. Most of the time, these folks are doing this work because they want to see cures. And this was a disease that was killing friends, families, left and right. And so people really were dedicated to find this. So I think that you should trust it, both because I think it was great scientific and excellent, outstanding work, and two, because I think that people really were looking to find something that would help people and not kill them.
I just want to add to what Pam said, just to give you a little bit of context. So Pfizer, they did clinical trials is what she's talking about. And in each arm, there were over 36,000 people in each arm that have participated so far and counting. So it's still going. And I think just to think about the salient point that Pam made is parallel development, clinical trials, and companies, scientific companies working with pharmaceuticals were doing it parallel as opposed to waiting till all things were done and then making the vaccine. The other piece of it is that you have Moderna and Pfizer are the purest vaccines I think I've ever seen. Actually, Moderna is like considered organic because there are no fillers, there's no preservatives, there's like nothing. There's a lipid coating and the RNA virus, an mRNA virus, literally. And that's why it has to be kept at certain freezing temperatures because it's not sitting on a shelf waiting around for anything. It has to be done. So you're getting top quality probably the first organic vaccine that I know about, specifically with Moderna. And there's been over, 80, almost, 78,000 people have been in clinical trials combined just with Moderna and Pfizer. That's not including the Johnson & Johnson, AstraZeneca, and so on and so forth. So I just want to reiterate that. And then the other part of that question is what if you never get the second vaccine? So you heard a lot of the information going around on television about, they were saying just to get the vaccine in people, let's just do one and call it one and done. And the efficacy of both the vaccines are a little bit, they're like 85%, and I think the other one is 88%. Pfizer is a little bit more efficacious, or basically works about in the 80 to 88%, versus if you got two vaccines and you're at 95% protection rate. So that's, if people don't get the second vaccine, that's what you're kind of working with, that you just don't have quite as an effective antibody response. Okay, so just know that. So we're not at this time, we're not advocating for one and done. We're advocating for two vaccines so people can have maximum protection and to do exactly what Pam has been talking about, and that is to minimize transmission or acquisition of getting COVID-19. So, yeah. Your next one is, you answered the question about, will COVID-19 give you disease? And then I think we'll go do Patrice's last. I'm going to go to Deidre's question, which was, she said, thank you for providing information. She said, she has family members that don't want to do it. Can you explain layman terms, the benefits, what we did, side effects, which has also been, goes to someone else's question about side effects of the second vaccine. So possible effects, consequences if we don't take the vaccine, which you did talk about. So I think we should talk about side effects. So that's come up twice. So basic side effects, and then Tom asked, what about, he's heard about side effects in the second vaccine when you get your second shot.
Okay, so all vaccines have one major issue with them, is that it hurts in the muscle that they put the vaccine in. So the muscle that you put the vaccine into, you're going to have what you call site tenderness, no matter what vaccine you're taking, okay? Now, when you get a vaccine, it turns on your immune system. And when it turns on your immune system, you feel that. That's what causes you, when you get a cold or the flu, that's what causes you to feel achy, feverish, tired, all of that. Now, that's all coming because your immune system turned on. When we give you a vaccine, we are purposefully turning on your immune system. Now, with the first vaccine, usually people get kind of a mild to moderate reaction. You get site tenderness, you might get some fatigue, you might get some achiness, maybe a headache. When you get the second vaccine, basically you're telling your body, did you see that last one? What about this? And your body sees it and it goes, I recognize this, I don't like this thing, and it really kicks up into high gear. That's where we get the biggest production of the antibodies against the virus. And it's going to cause a fairly good immune response. That's telling you that your body works, and it's working like it's supposed to work. So when you get that second vaccine, you might feel aches and pains in your muscles. You might feel a little fever. You might feel fatigued. Some people that I know actually got nausea. So those things can happen. And those are things that we expect to happen with a two-stage vaccine, okay? So the other flip side of that is on the day that you get the vaccine, they will tell you about symptoms to look for in case you are having an allergic reaction. And that is not normal, and that is not what you should expect. And that happens exceedingly rarely. Very, 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 very rarely. And if it does happen, what we do is we watch people for 15 minutes to half an hour after they get the vaccine. Because what we know is that if you're going to have a reaction to the vaccine, you're going to have it in the first 15 minutes that it's injected. So we're going to watch you for as long as it takes, well, usually about half an hour, but longer if we need to make sure that you're not having those reactions. Is there anything to add to that, Joycelyn?
No, I think that's perfect. And that's exactly what happens. That's standard. It should happen everywhere, anywhere that anybody's getting a vaccine. But I think the takeaway is that we think something is wrong if we have reactions to vaccine. And I explain this to my patients every day. They're like, I don't want to get the flu shot because every time I get the flu shot, I get the flu. And I say to them, exactly what Pam says, your body is working. It's a sign that your body is making antibodies to the flu, and that's great, and that's what's supposed to happen. But we're not used to feeling like that. We don't want to feel that way, right? And we don't want to miss work. We're going on vacation, and all of that. But these are things that are normal responses to vaccine. And you need to tell Deidre, I'm thinking about when you said you have adamant family members, you let them know this is normal. This is what would happen if you got a cold or you got the flu on its own, where you might have to lay in bed for a little bit because you're feeling down. So I appreciate your explanation. Thank you, Pam. I think the next one was Althea said, and then we'll get to Patrice's last. Althea said, is this going to be like the flu shot being given every year, this COVID-19? Will it have to be given every year?
And I'm going to give you a resounding, we don't know. Okay?
Great.
No, and if you ever run into a healthcare professional who's afraid to tell you that they don't know, run. So, no, we don't know. The scientists don't know. They're still doing that research. And it may turn out that, yeah, this is something we have to do every year, or it may be something we have to do every 10 years, like we get tetanus every 10 years as a booster. It could be any one of those things. But for now, we know that if we give people the injection, they will have antibodies at least out about 6 months. We know that. And what we're trying to do is get enough antibodies in people, along with masking, social distancing, and washing hands, to really lessen the amount of virus that's circulating in the community. The more we suppress that virus, remember they were talking about flattening the curve, the more we suppress that virus, the less people get sick, the less people die. And we said before, we know who's dying, okay? That's why it's important for us to have this conversation today. That's why it's important for you to ask all questions that you want to ask about the virus. And any healthcare professional who's afraid to answer your questions, again, run. So,
Yeah.
so ask away.
Okay.
I wanted to say one thing about ibuprofen. Sometimes people take ibuprofen before they go and get their flu shot because they don't want to feel the aches and pains. It's important that you not take ibuprofen before this vaccine, because you do not want to in any way quiet your immune system or subdue it so that it won't react. Soreness, tenderness, all of that, again, is your immune system turning on like it's supposed to. We want that to happen this time. So do not take ibuprofen before your shot. So if after your shot, you actually feel, the next day you actually are feeling achy, headache, you're really kind of waylaid by it, it's okay to take a dose of Tylenol or ibuprofen then. But wait until you actually have a need for the ibuprofen. Do not pre-medicate.
Great. And then I think our last question will open up to any clarifications, but our last question was, Oh, I went right past it. There it is. Okay, so how are you all addressing the equity issues? And I think that I'd like Mary to answer this question first, and we can chime in after her. But how are you all addressing the equity issues that are arising considering access? Can you speak to long-term strategy for vaccinating the community, cultivating trust while doing so, and making sure the data narrative basically is valid and transparent? Oh, this is a great question
Okay.
for Mary.
All right, thank you, Jocelyn. And thank you, Patrice, for that question. It is a very important one. And what we're doing right now is a demonstration of our response to the question and to the need. So what ARTH has been doing over these past few months is really collaborating and partnering with folks at King County Public Health, the University of Washington, and Fred Hutch, Seattle Cancer Care Alliance, and others in the community around how do we make sure that communities of color, particularly African Americans, are receiving access, have access to education, to the vaccine. And so what we are doing in that process, ARTH has developed a whole series of educational topics. We have, as last week, we trained peer educators so that we will have a group of people who can help to to spread the information, the knowledge about COVID and the vaccine throughout the community. But these educational topics that we have developed in partnership with others, we will be presenting on the average of 1 or 2 topics or presentations a month, at least through, we're projecting through the end of this year. So that's one piece, because, part of this is about the hesitation that people may be having about just taking the vaccine, has been expressed in some of the questions. And then that's compounded with maybe fears and just the historical experiences that African Americans have had when it comes to and working with health professions, and everybody, kind of goes back to Tuskegee and so forth, and the reasons why, the trust factor is so shaky when it comes to African Americans taking a vaccine. So the education is to help dispel the myths, or to build trust and confidence in this and the vaccine that are being offered. So that's one piece of this. So the other part is to also provide access to our community when it comes to the vaccine. And I think some of you have already gone through at one of the vaccination sites that we have worked with the Central Area Senior Center, just like we're working with New Beginnings, their health ministry. But the idea is that what we're doing is building these networks within the community where we frequent, in our churches, at the senior centers, and our organizations, that the grassroots of community that's accessible for African Americans and other communities of color can receive the vaccine. And this is all kind of, I want to say this is all grassroots led, because from the state to the county, city, everybody's kind of struggling with, well, one, there is just not enough volume in terms of the vaccine itself, and the distribution of that throughout the country. There are so many issues that we're facing. And then when you get to the community, and different organizations or institutions are allocated a certain volume of doses, their first priority is their people. And so we are stepping in to say, there has to be a more equitable way of getting this vaccine out. And so I have to definitely have to just kind of shout out for Fred Hutch Cancer Research Center, their COVID Prevention Network and their HIV Prevention Network, because they have bent over backwards to try to really make this an equitable access to the vaccine by sharing their allotment of what they're receiving. So this is how we were able to, working with Joycelyn and New Beginnings, we will have a vaccination site, a clinic on next Saturday. We were hoping for it today, but of course, nobody's going out in the snow today. So we're doing that next weekend on the 20th, and some of you are probably on the list to receive your vaccine. And the other partner was the Central Area Senior Center and a couple other churches, Mount Zion, First AME, the Seattle Fire Department, and Safeway Pharmacy. So we've held 2 vaccination clinics at First AME. One was on the 4th, I believe it was, and the other was on the 11th. And so this, the strategy is that you'll see more of this over the coming months as we continue to work with our partners and getting the vaccine out to you. So if you have any questions about where there might be upcoming sites, you can always give our office a call. And the one thing that I want to point out that is very important, and if anyone has gone online to try to access, to get out an appointment or to get registered through the state or through the county, there's never a person to talk to. I spent 4 hours just trying to search and find a site where there was appointment available, but was never able to talk to anyone. So what ARTH is doing, thanks to our wonderful Tawanda and all of her support, is that we have live people who answer the phones, call you back, talk you through your questions so that we can get you slotted. And then we do follow-up calls and emails. So there is that personal touch that we're doing, because we know that, particularly for our seniors, we need to reach them in a way that is, I want to say, comfortable for them. What the method that they're normally, and seniors like to talk. They're personable on the phone, maybe email, but definitely on the phone. So we factor all of those communication from a cultural perspective to make it relevant to our people. And so those are some of the things that we have done, are doing, and we have plans to do in terms of ongoing strategies in this work. So
thank you, Mary. That was amazing. And you really gave a well-rounded response to Patrice's question around equity with regards to access to this vaccine. I think Mary really highlighted one of the things I would like for our attendees to walk away with is, this is top down, unfortunately, with when it comes to distribution of this vaccine, and we got to get in there and grab it. And the fact that we're working with a reputable healthcare organization, Fred Hutch and Seattle Cancer Care Alliance, where they see the need, where they see, and that is because of their previous work in HIV. They understand transparency in this process. And so when she said bend over backwards, that's an understatement. And so we're very proud to have this alliance. And so I think that what you all can take away as far as education around this to your communities is that if you have an opportunity to get this vaccine, get it, because your opportunity might not come. So come again for a really long time, because political things are holding up distribution of our vaccine in an equitable way. I would love for Pam to stop sharing the screen for a moment and then open it up to any questions or comments from our participants.
Can I make one comment, Joycelyn? And I'm the technology person, and I know a lot of the vaccines that are being scheduled for people around the state they're using technology, and we're also running into that challenge with our African American elders and their fear of technology or lack of knowledge around it. So if you know people who are having trouble and they are young people, or if you know how to do it, we have to help one another with the technology piece, because they're not going to change their systems and say, okay, because our elders don't know technology, we'll just take everything by phone call. So we're going to have to shift. If there's a time that I can encourage you that it is important to learn how to get on these computers and how to do stuff, it is now. COVID is going to be around, so we're not even going to get back to in-person opportunities for a while. So please, 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 if you have trouble, if you're not sure how to use it, even at ARTH, we did 3 workshops with elders. They're on our website. The recordings, just like this recording, will be available for people to replay as well. So don't let technology keep you from getting access to what you need.
And may I add something really quick here, because I just what Tawanda has said. The other thing that we've done that I failed to mention is that ARTH has received fundings that has allowed us to purchase laptops and tablets. And with Tawanda's training, the training that she's referring to is actually working with our seniors, teaching them how to use the laptop, how to use the tablet, how to get onto Zoom and Facebook and so on. And so we have those laptops and tablets available and they're specifically for African American seniors. So if you know anyone who is a senior who needs a laptop or a tablet, give us a call and we can help get them set up.
Thank you. I think I know a couple right now. Okay, anything from, let's see here, we have left on is Althea, Patrice, Mary, Deidre, Tom. Please just unmute yourselves and if you have any comments or questions.
I first just want to say, this is Patrice. Thank you for putting this together. Thank you, Ms. Mary, also for stating that you all will be putting this on the website, and we'll be doing this multiple times, because I think, to your point, Ms. Tawanda, it is about access, but you know, the method needs to be varied, and so to have the multiple points of access, I think is really important. So just thank you also, Ms. Pamela, for sharing all of your great knowledge and walking us through everything and giving us the visuals and the rhetoric to take back to our communities, our friends and families. I appreciate you.
Thank you, Patrice. Anyone else have any comments or questions?
Good morning, everyone. This is Deidre. I just wanted to echo what Patrice said. I thank you all for your time this morning and sharing all this information. It's been very informative for me. I'm going to go back and share with my family as well as my friends. And I did just want to clarify, you said that this video will be available. Will that information be provided?
Yes, it's going to be on our website. So it'll be under the COVID-19 link or the YouTube link. So as soon as it downloads today, it takes a second to process. I will upload it today so that people can start watching, viewing, and sharing.
Okay, thank you.
Thank you, Deidre. I'm so glad you got a chance to participate. I know this was really important to you. Anyone else? Yes, Tawanda.
I have a question. Pam, you mentioned the double masking and that N95. And those N95s that we get online, they say they're not the official quality ones, but they are a tighter fit. Will that work? Or are we needing to really find the legitimate N95s that we can't find?
Pam, whatever you can't answer, I'll answer, and make sure you unmute yourself. There you go.
I think that it's important to have a mask that fits tightly. I hesitate to tell someone to get something that's not official. So what I've heard is this: if you are wearing let's say a surgical mask under and then even a cloth mask over, that's a good 2-mask system. If you have put together 2 of the blue surgical masks that we can get, that's a good 2-mask system. What's most important is that they fit on your face so that you don't have a lot of air coming in the top and the sides. If you can get the official N95s, you can wear an N95 and then a surgical mask. But I truly hesitate to say, oh, it's okay to get, an uncertified thing. Joyce,
Okay.
do you agree with that?
I do. I want to just clarify that a little further because I did a lot of research on N95s. So for the healthcare provider, we get fitted for our N95s. So if we're wearing we get fit tested, which means that they make sure that whatever they're ordering is going to keep whatever particles out of our N95 mask. So this happens once a year for every healthcare provider that's working in healthcare. So we get fit tested. Do you think you can get fit tested in the community? No. So I tell people, you can buy the N95. You don't think that it's necessarily the same quality as you're going to get in the hospital, because we're actually fit tested for that. So what Pam said is what matters is that that it fits over your nose and it's around your face like this. And if you're going out, it's not perfect fitting, put the other mask on top, which can be a surgical mask, or under and then over, either one. What matters with that second mask, if you're in the community, is that it's a tight weaved, non-disposable mask. And that's the piece that people are buying a lot of disposable masks, and those do not protect you. So you want something that has a tight weave on it. That's really important, along with something that's well-fitting if your tight weaved mask is not well-fitting. So they're saying, the CDC says you can wear double masks. We think it can protect you more. We do see that it keeps out more particles. The bottom line is to wear a good fitting, non-disposable mask if you're only wearing one mask, okay? It needs to fit.
Okay.
Does that make sense?
That makes sense.
Yeah.
I have one more question. So everybody is talking about, I know Valentine's Day is tomorrow and folks are planning on going out to dinner and they're talking about take your mask off, take a bite, put your mask back on. To me, aren't you cross-contaminating everything? Yeah, it makes sense.
I'm gonna answer that question. So in the clinics and hospitals, if we eat lunch, if we take break, we have to throw our mask away and put on a new mask. Okay.
Makes sense. Thank you.
So, the thing is that you should take some stuff with you. I mean, who's going to go out and, I mean, that's really cumbersome, but let's just say that you do. The bottom line is that once you have contaminated your face, basically you need to put on something clean. They want you to put on a clean mask when you're moving around. The bottom line is, literally the bottom line is to wear a good fitting, appropriate mask. Whether you're out to dinner, whether you're sipping wine at Valentine's Day tomorrow, it doesn't matter. You need to wear it, whether you got lipstick on it, whether you got your wine through it, okay? If you soil your mask, get rid of it, put on a clean one. But you need to wear a form-fitting mask, something that protects you. That's what CDC says is the bottom line. And anybody can go to just say CDC masks and it'll tell you. And they don't have a firm, it's not firm like everybody must wear 2 masks. They don't say that. It's a recommendation, okay? But they do say wear a good fitting masks, as Pam said. That's number 1. That's a great question. And let's see, Mary or Frankie, Althea or Tom, did you any of you guys have anything you wanted to ask or clarify before we close?
No, I just think that it was a great presentation, and I learned so much, and that's going to be helpful for me to prevent, hopefully getting the disease. And I just like to thank all of you, especially Dr. Saari, if I said that name correctly, I asked a question about the second vaccination, because I had some people that I know that one or two had to go home from work once they took it. But thanks for explaining that to me. So I'm ready to take my second shot next week. And
Oh,
that's
good.
All right, Tom. Let that immune system work.
There you go.
Yes. Thank you so much.
All right, welcome.
Okay.
I have nothing to add. I'm glad for just sitting in on the conversation.
Thanks, Mary.
Okay, I would like to know about, she talked about pre-medicating, not pre-medicating before your injection, and being a chronic pain sufferer. I usually take pain meds. Should I not take those the day of my vaccination?
Well, we were talking specifically about anti-inflammatory meds, like ibuprofen or Advil or meloxicam, or some of those that you might get from the doctor, but it's the anti-inflammatories. Now, if you are on an immune suppressive type of regimen, like you regularly take prednisone, like that, you continue your regular routine. This isn't supposed to disrupt that. I was mostly addressing people who wouldn't ordinarily take something like that. And then on the day of the vaccine, they go and they take a giant dose of ibuprofen. And so we don't want you to do that. That's the question.
Okay, thank you.
So this brings up a question for me, Pam, and the one that we dealt with on this past Thursday. So who should not take the vaccine?
Okay. I looked into this, and the answer to that is that the only people who should not take this vaccine are people who are allergic to this vaccine. If you have a history of having reactions to vaccines, anaphylactic reactions, then you should not. And what you should do is have a conversation with your physician about what you should do instead to protect yourself. Everybody else should be able to take this vaccine.
That is correct.
Okay.
That is
Okay,
correct.
that's good to know, because there was a person at the last vaccination site who was going through chemo.
Mhm.
And so there was a question if this person should have, was safe for them to take the vaccine. Thankfully, there was a physician there who we basically referred the person to, because we're not clinicians. So we referred that person to the physician that was there. And another person was there whose primary care provider, this person was on a certain type of medication, and they were basically told to stop for 3 weeks prior to getting the vaccine, and then to go back to it after the vaccine. So I just bring that up because these are some of the questions that we get just in folks calling to schedule their appointments, or once they're at the vaccination site, and as they're waiting, we have at the vaccination site, ART has peer educators, folks that are there to just kind of do chats and talks with people to answer their questions. And whatever questions we can't answer, we do refer them to the clinician that's on site.
That's the right thing to do, Mary. And that's why it's important to have medical director on site, because that person on site is going to be able to field those types of situations. Working in primary care, primarily where I see birth to death, and dealing with people of every genre you can possibly think of in society. I've, in the beginning of the vaccination, done lots of calls and education and calling rheumatologists and calling oncologists to make sure it was okay. And then just with all the guidelines that have come out, the bottom line basically is, as Pam said, anybody can get the vaccine. I have people on immunocompromising drugs for their rheumatology issues, et cetera, et cetera. And when this first started, they said, give the vaccine, please. What you have to understand is that people who are pregnant, people who are immunocompromised, like on cancer drugs, rheumatology drugs, HIV, they may have a less, their antibody response may not be as robust. So they have to understand that there may not have quite as I'm gonna use a big term, efficacious response as their non-immunocompromised counterpart. So they don't know exactly what that is. Is it 70%, 60%? Is it 90% versus 95%? So we don't know, but they do know that you may not get as a robust of a response if you're immunocompromised. So what that means is just that what my rheumatologists, oncologists, you name it, are like, get in there and get that vaccine, because I prefer you get that vaccine than get COVID.
So are they still, I know there's a big debate going on about women who are pregnant and because they were not included in the clinical trials. And so there's not the data to show how effective or harmful it might be in terms of the fetus. So there was a big discussion on that yesterday, and I just wondered about that.
Yeah, and so really, I would say that pregnant women, so right now, according to the American College of Obstetrics and Gynecology, they are for the vaccine. They are for women getting vaccinated, just like people were freaked out when women were getting the flu vaccine, okay, and getting Tamiflu if they needed it and things like that. It's sort of the same scenario. Yes, you're right. There is a debate going on around it, but right now the recommendation is to get the vaccine. With that being said, OBGYN groups are making their own decisions insular about how they will manage that. We don't right now have the ability to be able to give vaccine in clinic. So people have to go to community sites and or their pharmacies, which there are very few pharmacies giving out vaccine, right? So if we want pregnant women to have vaccine, we have to inform them and educate them around getting vaccine. And so that is where we tell people they must talk to their provider if there's any questions. So and when people say, well, I don't have a provider. Well, here you are, call ARTH, call the local health department. Mary said she was on the phone for 4 hours, and that's a problem. Call ARTH. We can find that answer for you. We can help field that for you. But right now, there's no indication that the vaccine is unsafe for pregnant women.
Thank you.
Mm-hmm. And that was a very long answer, but I can, as I get more information, because I get a lot of, I participate in a lot of education, I will, for providers, I will let you know if something like, comes up with as far as a statement is concerned. But that's a great, great question. So. Okay. So Mary, do you close us out or?
Yes, I do.
All right.
Okay. So, just really want to appreciate you, Pam and Joycelyn, for taking us through this presentation and giving us so much information, and I just want everybody on the call to know that, it is when you can sit in a presentation, one that's delivered by people that look like you, two, that you can have these informal conversations, questions answered by knowledgeable people and people that you trust, it's exceptional. So I just want to thank you so much for being on the call today, everyone. And Tawanda, thank you so much for being our wing person, technology person, and I don't know what we would do without you. Yes, and so just remember, everyone, to check we will be sending out, flyers for registration. One is getting that ready. We have a number of workshops. We just did one last week on COVID and depression or mental health because of this disease, where people are isolated, they're going through so many tremendous changes in life. And so we're looking at how is COVID impacting us as a people from a cultural perspective. So there will be a number of sessions coming up over these coming weeks and months. Check your emails, register, come online, tell your friends, and check in with us. So aside from that, I just want to thank you for being here. You can go out and throw a few snowballs or be like my neighbor who's out there shoveling his driveway. I said, what's the point? I mean, there's going to be more.
Or get in the pool like Twanda's about to do.
Oh yeah, go jump in your heated pool.
Oh, no.
Yeah, but have a wonderful rest of the day and weekend, and happy Valentine's Day to all of you.
Happy Valentine's Day.
Thank you, guys.
Yeah.
Thank you.
Thank you all.